Um, Good afternoon, everyone. Thank you for joining us to this lecture, and I'm grateful for Dr. Eduardo from National Institute of Medical Sciences and Nutrition from Mexico to join us. Eduardo is the next generation nephrologist and a thought leader in point of care ultrasound. He is going to share his own experience, how he's brought about a Pocus revolution in his own hospital, and how using point of care ultrasound you can revolutionize the way you manage cardiorenal syndrome patients. Thank you, Eduardo, for your time, and I look forward to this interesting talk.
Well, thank you, Civic. I am really honored to have been invited to speak with you guys. And I'm going to make this presentation very physiological one. It's called Pocus Revolution, a journey to conquer cardiorenal syndrome. And let's just dwell into it. I'll start with a little bit of history. Like, how did I get into this world? As I am a nephrologist, how did I get ultrasound started? And it started when I met this guy, who's called Philip Rolla. I met him online. He was doing this this was back in 2020, 2019 actually. Look, here is the date. This is 2019. He was publishing online that he was evaluating heart failure using portal vein ultrasound. And the first time I learned about it, it sounded crazy. And so I said, I need to meet this person. I need to be his friend, and I need to learn from him. So I started writing and reaching out through social media. And eventually he shared a video. This is a video where he taught me the technique to evaluate the venous Doppler in the portal vein. And I wouldn't have imagined this would change my whole practice. I had this machine, which was the first ultrasound machine our hospital bought. This is a sonocyte machine. And this got me an idea. I needed to work with this guy, with Philippe Rolla, to create knowledge, because nobody was doing this anywhere in the world. So we started doing a case series. We began with a case series following decongestion in heart failure using portal vein Doppler. And it was just a small case series. I didn't think much of it. We sent it to a small conference in Florida, and little did we know, we won the top presenter award, and then the story began from there. So I'm going to go back, and I'm going to say, why should we use point of care ultrasound to evaluate cardiorenal syndrome? Well, of course, this is the patients we see. We see patients with acute heart failure, with a lot of pulmonary infiltrates, jugular vein distension, and oliguria. And that is very common problem in the practice of nephrology. So if we had perfect physical examination skills, we might not need the point of care ultrasound, but physical examination is really hard. And there's a lot of evidence. This is evidence from the LOST trial. This is from C. Jason, just published this a couple years ago, who shows that our skills of using lung auscultation to determine whether there's lung congestion are pretty bad. So you can see here, this is an ultrasound example of lung congestion. These are pulmonary artifacts, B lines, that come from the pleural line. These are horizontal artifacts that are called the B lines. And this is a normal lung ultrasound, an A pattern, which are horizontal versus vertical artifacts. You see, vertical artifacts are the B lines, and this represents clinical congestion. And so if you see the number of B lines that appear in different patients, and that physicians would say no crackles, uncertain crackles, or very severe bilateral coarse crackles, you'd see there's really not a good correlation between what the physician can say and what the actual number of B lines in the lung are present. So we are really bad at determining lung congestion by using auscultation. And we are also bad at examining chest x-rays. This is much better to do lung ultrasound. What other things are we bad at? We're very bad, we're terrible at estimating CVP using jugular venous pulsation. This is a beautiful study. This was done by emergency department physicians who did not know they were being evaluated on whether they are good at assessing jugular venous distension. And another investigator came and actually measured the CVP and tried to correlate with the assessment of the emergency department physician. And as you can say, the physicians would say the jugular venous pulse is very elevated or is normal, and the CVP would be no different between these groups. So we're not very good at assessing CVP clinically. And so this is very important because cardiorenal syndromes would cause organ injury, would cause liver, kidney, and other organ injury by different mechanisms. Now, the most relevant mechanism is the transmission of elevated CVP back to the organ. So it will be transmitted to the liver, it will be transmitted to the kidney, and it will cause congestive hepatopathy and congestive nephropathy. And so, because this is the main mechanism of organ damage, assessing CVP has to be one of the most important skills a physician taking care of this patient should possess. Not only that, this can be done really easily at the bedside. I mean, everybody who does point of care ultrasound knows about the inferior vena cava. And this is just an example. Here in the right is my own vena cava. You can see it here. You can see a normal plethoric, non-plethoric IVC that collapses with respiration. This is a long axis IVC, and this is a short axis IVC, which collapses with respiration. And here in the right, I'm showing a patient with heart failure. This is a plethoric, non-collapsing IVC. You can see the difference. It does not collapse with respiration. It is dilated. And if we rotate the probe 90 degrees, you will see a circular, completely circular vein that does not change in shape with respiration. So that's how everybody does it. That's the usual assessment of venous congestion. However, we all know the IVC has a lot of problems, especially because the diameter of this vein depends on the respiratory effort that the patient is doing. So, for example, this is a beautiful study. It's called sonospirometry because somebody is measuring inspiratory pressure at the same time they're measuring the IVC. And these are all patients with severe heart failure with a CVP greater than 20. And you see that even in these patients, when they do enough respiratory effort, so the investigators, the researchers tell them to do a very strong respiratory effort, the IVC will collapse when they reach an inspiratory pressure of 20, of course, because now the inspiratory pressure is greater than the CVP. So this might cause false venous collapse. It is also affected by mechanical ventilation and many other factors that make it a less than reliable tool, though it is still pretty reliable and should be the first step in assessing venous congestion. But we can go further. We can use the physiology of pressure transmission from the right atrium to the peripheral organs. So normally, if you remember the CVP, it is a pulsatile pressure. So it changes during cardiac cycle. We got your A wave, your C wave, your V wave, and your X and Y descents. And this pulsatile pressure will be present in the right atrium and will be transmitted into the veins that are immediately adjacent, for example, the hepatic veins. But this pulsatility will not reach the venules or the capillaries because it is dampened, it is attenuated by our veins that are very distensible and non-congested. And so our flow will usually look like this. When we get a artery and a vein, we will get an arterial tracing above the baseline, which is pulsatile, of course, because arteries are pulsatile. But below the baseline, you will see a flow that is non-interrupted and almost continuous. When we have venous congestion, our veins are distended and the wall can no longer accommodate any fluid, any more volume. And so any change in pressure from the right atrium will be easily transmitted into the venules and into the capillaries. And it will cause increased venous pulsatility that will manifest, for example, in the kidney as a very severe, you see the difference is a very severe interruption in renal flow. And now we do not anymore have the continuous flow. You see a very prolonged interrupted flow with just a small amount of time of venous return during each cardiac cycle. And this is severe venous congestion. Now, the first person who described this was Noriko Ida. He described this in patients with heart failure, acute decompensated heart failure, and also stable heart failure. He described these three patterns: the continuous pattern, the biphasic, because there are two interruptions, so biphasic, and the monophasic, because there's only one a small wave of venous return during each cardiac cycle. And not only that, not only did he describe the patterns, he showed that with every increasing pattern of congestion, you will have a worse outcome. And this was the main determinant of outcomes in this population. This was replicated by the group of Kofrani in pulmonary hypertension, where the most severe renal congestion you have, the worst outcome you will present. And this was the single most important predictor of outcomes in this population. It was more important than the CVP. Actually, if you look at in this paper, the correlation of the CVP or right atrial pressure with renal congestion is moderate, but it's not great. As I have pointed out here, you can have a CVP of 10 and a completely normal renal Doppler, but you can also have a CVP of 10 and a very severe congested kidney. So it's not a perfect correlation, but I do believe it offers us more information than the CVP, because it's not only a value of CVP, it's also the physiology of the transmission of this pressure to the kidneys. And that has to do with venous distensibility, as I have shown you before. And so if you see the predictors of mortality in this population, more important than the pulmonary artery pressure, than the CVP, than the cardiac index, more important than all of those was the renal Doppler. It was even more important than all the clinical factors that were studied in this paper. So renal Doppler was the single most important independent predictor of mortality and morbidity and rehospitalizations in this group of patients. So you see why this is important to assess at the bedside. This also been done in patients, in critically ill patients. This is now just recently published, 15 days ago. This was published on July 10. And you can see this was published by the original inventors of the intrarenal Doppler. This was by the group of Noriko Ida. And they showed that in patients, in critically ill patients with sepsis, you can find some of them that have interrupted renal flow. And this interruption in renal flow occurred in patients even at the same CVP that those with continuous renal flow. So, you know, this is a more sensitive tool than actually measuring the CVP. It not only detected renal congestion, it was associated with higher fluid balance, and it was also associated with an increased probability of acute kidney injury, severe kidney injury, that says KD goes stage 3, or death. So, you know, authors here are proposing that the renal Doppler is actually more sensitive than using an invasive measurement such as CVP measurements. Now, there are some problems with the renal Doppler. Sometimes it has a hard window. It's hard to find the blood vessels. It takes a lot of time. If the patient has a lot of respiratory motion, you will have a nightmare of a time trying to find these small intrarenal vessels. And of course, in the patients I see, I'm a nephrologist with chronic kidney disease, but they have very thin parenchyma. And so sometimes we will not find these beautiful interlobar or arcuate vessels. And so for that, we have wondered if we can use a surrogate of intrarenal vessels to evaluate flow and this in a more accessible area. And one of them is the portal vein. The portal vein is my favorite. Why? Because it's such a large vein. The portal vein is a very large vein, very easy to find, very easy to scan. It has a very good acoustic window because the liver is a solid organ, so it gives it a very good acoustic window. And here you can see a normal portal vein, which has a continuous non-pulsatile flow. And as congestion progresses, it can become all the way very severe congestion. It can become very pulsatile. You see, because pressure is being transmitted from the heart across the liver sinusoid all the way to the portal vein. So whatever is happening in the portal vein is also happening at the level of the capillaries, because the portal vein is a pre-capillary vein. So you'll see when portal vein is very congested, you will see this severe increase in pulsatility, such that the normal is that it's non-pulsatile. Moderate congestion is considered when there's a 30% variation in velocity, so that's a 30% pulsatility. And severe congestion, this is how I define it, it's considered when there is greater than 70% increase in variation in velocity, so 70% pulsatility, just like this one. This one is severe congestion, greater than 100% pulsatility, because it is even getting some retrograde flow or some backflow into the gut. And so we had a hypothesis that this would be a very excellent tool to assess heart failure even without doing the renal Doppler, which is harder. And now we have this work that's been just accepted for publication. It should come out in the next month, where we have shown that there's an excellent correlation between the portal vein alterations and the renal vein alterations. I did not write the statistic here, but the R was 0.92. The R squared was 0.92, the R was 0.98. So it's a perfect, almost perfect correlation between renal congestion and portal congestion, of course, because this represents back pressure from the right atrium. And here you can see that if your renal Doppler is normal, your portal Doppler is going to be normal. And if your renal Doppler has severe congestion, then you're going to see severe congestion as well with your portal vein Doppler. So these are an equivalent measurements in most of your patients. We have also shown that increased portal vein pulsatility increases the probability of death or requiring renal replacement therapy in patients with pulmonary hypertension. So we are seeing the same results as the group of Gofrani. It's a very strong predictor of renal outcomes in patients with heart failure. There are more evidence supporting the use of portal vein Doppler as a way to assess the cardiorenal syndrome. This comes from the group of André Denot and William Beaubien-Souligny in Canada. And they have shown in patients undergoing cardiac surgery that portal vein pulsatility, this is the portal vein Doppler, is the single most important population. This was better than CVP. This was better than a clinical predictor of AKI, and this was better than echocardiographic measurements. So an increased portal vein pulsatility greater than 50% is associated with an increased hazard ratio of severe acute kidney injury. Look at the hazard ratio, 5.12. So there's some evidence, and we're continuing to build it, that the portal vein is a very good predictor of congestive kidney injury in patients with heart failure. Not only is it a good predictor, it's a good marker to follow, to monitor during decongestive therapy. Here is our first case series that now we got to publish with Dr. Philip Rolla, where we followed patients with cardiorenal syndrome, both with left heart failure and predominantly right heart failure, so that's pulmonary arterial hypertension. And we show that in every case of cardiorenal syndrome in this population of patients, the portal vein pulsatility is very high, greater than 30, greater than 50 in most of them. And after we give diuretics and we resolve the congestion and cardiorenal syndrome resolves, portal vein pulsatility normalizes. So this can be a tool to monitor how well is our decongestion going, because it was normalized in every case. And now if you go to the IVC, you will see there is a problem. Well, patients with left heart failure can be decongested all the way to a normal IVC, normal inferior vena cava. But patients with right heart failure, we could never decongest the vena cava because they have pulmonary arterial hypertension. They will always have a little bit of increase in right filling pressures, and their IVCs are always plethoric. That's how they live. That's a basic baseline for them. So then it's not useful to monitor. Look, it's the same before and after decongestion. But we were able to monitor all of them, regardless of whether there's right heart failure or left heart failure, using the portal vein pulsatility fraction, and I find that very interesting. Now, this is another good study by the group of Guinot. These are cardiac intensivists, and they have a purely cardiac ICU. This is done in France. These are very good researchers, and they studied the use of the utility of portal vein Doppler and renal vein Doppler to predict adequate response to diuretic in an intensive care unit. If you only read the title of this paper, you will not notice that this is a cardiac ICU. You have to read the methods of this paper, and I am saying this because I believe this is a tool which only has good evidence in the setting of heart failure. Though I have shown you a paper in sepsis, but most of the evidence comes from heart failure. And what did Guinot show? Look at this. Guinot showed that the best tool for predicting a good diuretic response in the ICU was the portal vein pulsatility fraction. It was superior than the renal vein here in green. The portal vein is the red line, which has the greater area under the curve for predicting good diuretic response. Then the green line is the renal Doppler, which is also good, but not as good as the portal vein. And then finally, there's a score that combines the portal, the renal, and the hepatic vein that is called the Vexus score. that actually performed a little bit worse. And in my experience, it also performs a little bit worse than just using the portal vein. And actually, the hepatic vein was not useful at all, so it doesn't even appear in this graph. So we have spoken about how to assess, not only how to assess elevated CVP using the inferior vena cava, but also how to assess transmission of the CVP into the organs using actual Doppler flow, venous flow. So portal vein pulsatility, elevated portal vein pulsatility, or interrupted intrarenal venous Doppler is giving us more information than just knowing the value of the CVP. It is telling us how this pressure is being transmitted into the kidneys, into the liver, and this might explain. This actually explains why this is a very important risk factor for developing organ injury in patients with heart failure. However, this is not the end of the story. Low cardiac output is also an important mediator of organ injury, although albeit I'll admit in a very small percentage of patients presented with cardiogenic shock or very low cardiac output states, they will have, of course, the classical liver ischemia and kidney ischemia, leading to ischemic hepatitis or acute tubular necrosis. So how should you assess cardiac output? Well, one important parameter is evaluating left ventricular function. You know, the left ventricular ejection fraction. Can this be done by non-cardiologists? Yes, this can be done by non-cardiologists. Look, this is a publication in Chest, which they used residents and fellows in intensive care medicine. And these people were trained only with 2 hours of didactic instruction, 4 hours of hands-on training, and then independent daily study for 2 months. And then they were assessed on whether they could determine if LV function was normal, mild, moderate, with a mild or moderate decrease, or with a severe decrease, in left ventricular function. And as you can see, it has an 82% of agreement. Using this training, they can get an 82% of agreement with an expert cardiologist. So look, how do we do this? We do 3 simple steps. This is for beginners. You can actually learn this in a workshop, in a 2-hour workshop, as this paper suggests. There are some signs that we can get. This is a parasternal long axis where you will see the left atrium, the left ventricle, the right ventricle, and we will look for subtle signs of left ventricular function. The first one is myocardial excursion. This is the number 1, where the endocardial borders should be coming together. The second one is the myocardial thickening. This is the actual septal wall and free walls should be getting thicker. And the third one is the motion of the anterior leaflet of the mitral valve. It should be moving towards the interventricular septum. It should actually be touching it, almost touching it. So here's an example. Look at the endocardial excursion. This is the endocardial border, and look how it's getting closer together. Look at the myocardial thickening. Look at how it's getting thicker. This is the septal wall, this is the free wall, and it's getting thicker. And finally, look at the anterior motion, the motion of the anterior leaflet of the mitral valve. Look how it's almost touching, as if it's almost slapping the interventricular septum. So this is a very good and normal left ventricular ejection fraction, or normal LV systolic function. Now compare it with this one. This is a very depressed left ventricular systolic function. Look, the endocardial excursion is almost none. There is no motion towards the center. The myocardial thickening is gone. Look at the septal wall. It's not thickening at all. The free wall is maybe slightly thickening a little bit, but it's very bad. The myocardial thickening is very bad. And now look at the motion of the anterior mitral valve. Look, it's very far away from the interventricular septum, right? So this is severe LV dysfunction. And of course, you should expect in a patient with cardiogenic shock to have a very severe LV dysfunction. Now, there's other stuff we can do. We can actually measure cardiac output or estimate cardiac output by measuring the flow that goes through the aortic valve. And this is done by Doppler, by using pulse wave Doppler of the left ventricular outflow tract. So we put our Doppler cursor right below the aortic valve, and we will get flow with each cardiac cycle. And now this flow is proportional to cardiac output. You can actually calculate it by measuring the diameter of the aorta and doing some fancy calculations, but many authors suggest this is not really needed because there's a lot of error in a more complex measurement. And just measuring the area under the curve of the flow in the left ventricular outflow tract, this area under the curve is a surrogate for a stroke volume. This could be enough to say, okay, stroke volume is normal, stroke volume is very high, stroke volume is very low. So for example, normal, this is the velocity time integral because it's an area under the curve of velocity and time. The normal velocity time integral is 18 to 22 centimeters. Okay, so if it's really high, if VTI you measure it and it's really high, it's like 30, then it's high stroke volume. And if it's really low, I mean like 10, for example, then it's very low stroke volume. And you can get an idea of cardiac output just by doing this simple measurement. Look, in this example, this is a patient with cirrhosis, has a very hyperdynamic circulation and a very high VTI. This is 30.8. So this is really high cardiac output. So this is a tool that you can use to assess circulation in patients with suspected cardiogenic shock. So here's an example. This is a patient who presented to our center with dyspnea, hypoxemia, and oliguric AKI. And you see this patient has a lot of B lines, right? So a lot of vertical artifacts coming from the pleural line. So is this cardiogenic shock? Is this just your classic acute decompensated heart failure? The patient is not producing urine. So it's a very good strategy to do some more advanced monitoring. Is this congestive nephropathy? So look at the IVC. The IVC is collapsing, right? So then CVP or right atrial pressure maybe is not that high, but you have to be careful because the patient has pulmonary edema. So maybe the patient is doing a very increased work of breathing and a lot of effort, breathing effort, and it's collapsing or falsely collapsing an IVC. However, we can look at the portal vein and ask the patient to hold his or her breath a little bit, and we see this is non-pulsatile portal vein, so not severely congested, right? So this is not likely to be congestive nephropathy. So why is this patient not producing urine? I mean, the explanation is not congestive nephropathy, but look at the heart. And now when we look at the heart, then we get the answer. This is a severely depressed left ventricular function. Look at the myocardial excursion, it's almost none. The myocardial thickening is not happening. And look at the mitral valve is barely opening. This is the anterior leaflet of the mitral valve and is very far away from the interventricular septum. So cardiac output should be really low. We can, go one step further and actually measure it. And this is what we got. This is the LVOT VTI. We are exactly below the aortic valve, and we get this VTI, which is very low, 10. I said the normal was 18 to 22. So the reason this patient is not producing urine is because forward flow, so stroke volume, is really low, and not that back pressure is really high. So congestion is not that severe, but forward flow is really low. This is cardiogenic shock by definition because the organs are suffering from low cardiac output, right? And so, this patient was diagnosed with lupus myocarditis, and we decided to start an inotropic drug to try to increase cardiac output. And you see, immediately, I did this evaluation, reassessment, 15 minutes after the infusion of the butamine, probably 30 minutes after the infusion of the butamine was started. And you see the change. Now we have a VTI, which is almost normal, 17.3. The normal was 18 to 22. And now I can make sure my drug intervention has worked and the kidneys are now being perfused. I did not show, I forgot to add the slide, but the urine bag started to fill almost immediately after 1 hour of the butamine treatment. So finally, I want to touch on other stuff that we can do with point of care ultrasound. And this is, our classic patient, as I showed you in the beginning, that has probably pulmonary edema, but we're giving diuretics and diuretics are not working. So how should I troubleshoot this? Okay, I have shown you. First, we need to assess whether there's severe congestion. Could this be congestive nephropathy? We have to assess cardiac output and left ventricular function. So is this cardiogenic shock? But there are other stuff that are more frequent and that you do not need to forget. And one important assessment is just to go and look at the kidneys and go and look at the bladder. Maybe you'll find hydronephrosis and a dilated bladder with a lot of urine, and maybe your Foley catheter was not working. So, and this is very easy to look with point of care ultrasound. Here in this example, you see this is a patient that did not produce urine and was severely congested. We looked at the portal vein, it was normal. So not severely congested in this systemic circulation. Of course, the lungs look pretty bad. Look at the cardiac out, look at the left ventricular ejection fraction. It's completely normal. Myocardial excursion looks good. Myocardial thickening looks good. And the anterior motion of the anterior mitral valve is also normal. Look, it's touching the interventricular septum. So why is this patient not producing urine? Well, look at the renal ultrasound. The kidneys are 7 centimeters in size. You cannot longer see the cortex. This is chronic kidney disease. This patient had severe long-time diabetes. And, you know, this is not a cardiorenal syndrome. This is actually a renal cardiac syndrome, which, you know, this is a primary kidney disease that is creating volume overload and causing heart failure. So this patient is not suffering from any hemodynamic alterations to kidney perfusion, but is rather having a progressive CKD state that has now reached the time for dialysis because is now presenting with severe volume overload, despite pretty normal hemodynamics. But now the kidneys, we can immediately see these are very chronically scarred and small kidneys, and this is a renal cardiac syndrome. This will not be fixed with diuretics, of course. And so, just to continue with the story, that began by me and Philippe winning this award from the University of Florida, we have kept on working on venous congestion and the assessment of venous congestion, and it's been a hell of a ride. Look, we have been, in the past year, we have been able to publish more than 10 papers of how to assess venous congestion, some original investigations, some reviews. We're still working, and this has allowed me to become a leader in this field because we began this field. And, you know, I just wanted to show you, so you get an example how we have been able to travel all over the world. I've been in Argentina, in Buenos Aires. Here's an example of a Pocus Fest we did in Guatemala. This is one of my proudest moments. I could be part of the faculty of the Kidney Week in the American Society of Nephrology. I was teaching top-notch nephrologists how to do portal vein Doppler, IVC assessment, and just some basic cardiac ultrasound. We're part of the faculty of National Kidney Foundation Pocus meetings, which are happening all over the country in the United States. I have been able to meet amazing people. Here's Dr. Anwar. I've also been able to meet the board members and board presidents of the EACVI. This is the European Association of Cardiovascular Imaging. I participated in lectures with them. This is Hatem Soliman. This is Dr. Victoria Delgado, who is the actual elect president of the ACVI. I have also been able to meet now rock stars of medicine. This is Dr. Guadalupe Garcia Sao, who is the most expert person in cirrhosis and acute kidney injury. She works at Yale University. So just so to let you know where my trip has got me, it has got me to meet very important and very interesting and very good friends, but also has led me to travel all around the world teaching how to use point-of-care ultrasound to assess not only our cardiorenal patients, but all our renal patients. And with this, I will finish. These are my conclusions. I would say the evidence is very good that Pocus is superior to classical physical examination for evaluating residual congestion, lung and venous, that severe venous congestion is the main cause of worsening kidney function in patients with acute decompensated heart failure. This is more relevant than low cardiac output, but low cardiac output is also a cause that should be assessed. Portal vein pulsatility is, in my opinion, the best echographic parameter to monitor the congestion, especially in right-sided heart failure. That should be heart failure or heart disease. In patients with suspected low cardiac output state, then besides evaluating venous congestion, it is useful to evaluate the left ventricular ejection fraction or the left ventricular systolic function and the flow in the left ventricular outflow tract. So that's your LVOT VTI. And do not forget the most important, because it's the low-hanging fruit. Do not forget bladder and kidney ultrasound, right? You will sometimes diagnose hydronephrosis, but sometimes you will just diagnose a non-working Foley catheter. And this is very important because it takes 3 seconds to look at the bladder, rule out a hydronephrosis, rule out advanced CKD with a very small kidney, and then if you see a very small kidney or very chronic kidney disease, then you know you're dealing with a renocardiac syndrome, and you're very unlikely to fix the kidneys by fixing hemodynamics. Maybe it's time to begin dialysis in these patients. So, you can assess all the axes: venous congestion, cardiac output, left ventricular function, but also how the kidneys are doing themselves. The size, the amount of parenchyma, the amount of cortex, the thickness of the cortex, the size of the kidneys, and whether there is urine in the bladder or hydronephrosis to rule out obstruction. So with that, I will finish my talk, and I'm here for any questions that you guys have. Thank you for your attention.
Thank you, Eduardo, for this excellent talk. And each time I hear you, I learn something new. And this was an amazing talk. Eduardo, I've got a few questions for you. And in the audience, if people have any questions, please feel free to type in the chat box, and I will put it to Dr. Eduardo. Eduardo, you're a nephrologist. How have your colleagues in cardiology and radiology accepted you doing this?
Yeah, well, it's been pretty straightforward and easy for me. I work in a very open institution. We are in the National Institutes of Health of Mexico, and so people there are used to innovation and get thinking outside the box. We're not very big guideline followers. We try to think of ourselves as guideline writers, but of course there's going to be some frictions. So people in our center were not doing point of care ultrasound before, not even in intensive care medicine, which I know in many parts of the world it's already happening. So the first time I got a probe and I tried to learn, for example, to look at the IVC, I took some pictures, I recorded in my phone. I wanted to make sure I was doing it, I was doing it right. So the first time I learned, I didn't have any mentors because I learned this by myself or through the internet. And then, of course, you have to find mentors. And I went to the radiologist, and they weren't very helpful. They would say, no, you should not be doing this. This is our job. And I said, okay, I know this is your job, but maybe you can teach me and we can do it together. And they weren't very receptive. Then I found out they actually didn't care much for doing, vascular assessment and IVC. In our center, radiologists did not even know how to find the IVC. So I went to cardiologists, and I was very fortunate to have a very outstanding cardiologist, who's Dr. Zulma Vasquez. He's one of our expert echocardiographers in our center, and she was completely receptive. The minute she saw the images, the first thing she said was, "This is a beautiful image, that one you got." So instead of trying to mark her territory or defend her privileges of doing ultrasound, she was very receptive. She was very open. She started teaching me. She started coaching me, and then she would call me to the echocardiography lab to just be with her and learn to do echocardiography as an echocardiography fellow. And she knew I was a nephrologist. She wanted us to be doing this in the floors. And we've been working together ever since. Actually, just last weekend, this weekend, I was with her in the National Society of Mexican Echocardiographers. and I was a speaker at her event, and now I'm a board member of the Mexican Society of Echocardiography, because everything she's taught me is been very useful. And this is things that cardiologists were not even doing. They were not very good at assessing venous congestion. I am seeing way more patients with cardiorenal syndrome than them, because, you know, of course, we work in a cardiorenal unit. So I think it has been a very useful collaboration, and I had no issues. But I can understand this could happen in other centers.
Yeah, I think you answered my second question is how do you learn? And it's a question of finding mentors, finding like-minded people, and continuous learning. Now, you have learned. How successful have you been in diffusing your knowledge? I know online you are a rock star, but in your own institution, how are they now embracing this? Are your next generation embracing this? And are you speaking the same language now in ICU, in nephrology, in cardiology, in internal medicine?
We are. When I began doing this, nobody was doing this at my center. I showed you the first ultrasound machine that we had. That was the only machine for the whole hospital. So that machine was in the emergency department, and I used to ask permission to take it everywhere. So I would take it to the medical wards, I would take it to the ICU, I would take it to the down escalation units, but we only had one machine, and it was mainly used for procedures, right? So people would just use this machine to guide procedures, for example, thoracocentesis and central venous catheter placement, but nobody was doing, point of care ultrasound or enhanced physical examination. And I just kept doing it for maybe 1 year, 2 years. This was 2018, 2019. And people were starting to pay attention, because I was just kept doing it, kept talking about it, kept showing people how their physical examination might have not been complete, and now look at these images. And through repetition and through a lot of being incisive and telling them once and again, people started noticing. But then something happened, COVID happened, and our hospital transformed. We stopped being a tertiary care center, and we transformed into an only COVID unit. So all our beds were COVID patients. We were in charge of the makeshift ICU. Actually, myself was in charge of the makeshift COVID ICU. And then, because we're National Institutes of Health and we were taking care of very sick patients, and point of care ultrasound was beginning to become, relevant, our hospital just bought like 15 ultrasound machines. And so we have now one in every floor, maybe 3 in the emergency department. We have 4 machines in the ICU, 4 in the downscalation unit. So the availability of machines was impressive. And now, because of COVID, we were doing a lot point of care ultrasound all the time, because, moving a patient with severe pulmonary distress syndrome is very hard to take them to CT scan. So we were learning now long ultrasound and specifics of hemodynamic assessment during the pandemic. And I used to be I became one of the leaders of my institution, because I had to train all the physicians to do this, and we were taking care of patients this way. So I think COVID just accelerated the way we acquired knowledge in ultrasound. And of course, we had very good mentors. The cardiology department was always there to give us feedback and also perform the exams themselves, so we could compare our exams with theirs. So, I think it was a combination of my insistence on, just talking to everybody, showing them the technique, showing them the results, and then at the correct moment, the pandemic just arrived, and this exploded, because now we had the resources to buy machines, but also the necessity to assess the patient at the bedside, because you cannot take a very ill patient to the CT scanner every time you want. So this combination of factors created a ultrasound-friendly atmosphere. And now that the pandemic is over, we have a lot of physicians that have been formally trained in ultrasound. And yes, of course, now we all speak the same language.
There were 2 questions from the audience. Any explanation why vena cava index was better than Vexus score in the study you showed, from Dr. Hussam?
It was not. It was not. Vena cava index was not better. than VEXA score. Vena cava index is continuously in different studies been shown to be less predictive than venous Doppler for worse outcomes in many populations, post-surgical patients, acutely compensated heart failure, pulmonary hypertension. This has been shown again and again that venous Doppler is superior than vena cava index. And why? Because vena cava index will only reflect the pressure in the CVP, but will not give you information on whether this pressure and these changes in pulsatility are being transmitted to the small parenchymal veins of the kidney or the capillary beds. And so, this is why I believe venous Doppler is superior. Well, not only I believe, the evidence says it's superior for predicting outcomes, but I also believe it is better to titrate or to monitor therapy, and that we are producing evidence that it is. Of course, it's a very good tool for monitoring, but we have to produce evidence that it will lead to improved patient outcomes. There are 2 randomized trials that are coming from Mexico that have shown some good results. I am not participating in them, but I have seen the preliminary results, and I'm sure people are testing this elsewhere. So we'll just have to wait and see the evidence, but I can bet it's going to be good. I can tell you, I've seen the result of 2 randomized trials now, and it improves outcomes. It improves hospitalization days. It improves the time, the amount of patients that get decongested. So I think using venous Doppler will turn out to be a really important tool in the future.
One more question. How do you choose the orientation of the gait when performing pulse wave Doppler to get a good assessment?
Yeah, so the technique is, there are many tutorials online, and this is easy to teach. So the orientation, I use a phased array probe, so that's a cardiac probe. Why? Because it's lighter, and I get tired when I'm doing a lot of ultrasound with the abdominal probe. So I use the phased array probe, and the orientation of the probe marker goes towards the patient head, and I place the probe in the mid-axillary line. So I am next to the liver, in the right mid-axillary line, with the marker oriented towards the patient's head. And this, I get a very good look at the liver. And this, I see the hepatic vein, I see the portal vein. It's just a matter of tilting up and down. But mid-axillary line at the level of the liver, which is almost in the xiphoid process line. So this is the place where I begin. I put the probe mid-axillary line in the xiphoid process with the marker towards the patient's head, and I will be right on top of the liver. And it just takes a little bit of tilting anteriorly. If you tilt anteriorly, the portal vein will show up. If you tilt a little posteriorly, the hepatic vein will show up. And this has a success rate of 100%, even in obese patients. We have published this result. Well, we're about to publish these results. It's probably going to be published this month. Our success rate of getting portal vein with this technique is 100%.
Right. There's a comment here. Thank you very much. Really enjoyed it. I think so. That was my impression of the talk. It's an amazing talk. In 30 minutes, you explain how Pocus can revolutionize how we manage these patients. In order to finish off, I want to ask a question. I mean, you're 10 years younger than me. You're already a thought leader in your field. I mean, in our field, it's a hierarchical system. Older you become, you consider to be wise. Now, someone like me is looking up to you for wisdom and thought. So how did you build this thought leadership?
Yeah, I would have to say that a strong social media presence was fundamental. Why? Because people start respecting your ideas when very important physicians all around the world are respecting your ideas, and the only way to get in touch with them is through share. Is through social media, sharing of cases, clinical cases, conversations, discussions. And now I've done this through Twitter at the beginning. I would post my own cases and discuss how I analyzed it, how I did point of care ultrasound. Of course, the advantage of social media is I can share some images with patient consent, and then everybody would get to see what I saw during the point of care ultrasound. and people started noticing it. I used to upload very nice example of cases where point-of-care ultrasound actually changed management, or new tools that we're using, so portal vein Doppler, intrarenal Doppler. And I was fortunate that some very important people started noticing, so people all over the world began to have discussions with me and recognize my work. And I was actually, I got invited, for example, to the Cleveland Clinic in the United States to give a lecture just because somebody met me online. And this was the first step, I think, to become a leader in this field, was to get recognized by people who are now were already established leaders. And publications matter a lot, because not everybody's on Twitter. So for people who didn't, I couldn't interact through social media. Well, then I have to get known somehow, or I needed to do something to be noticed in the field. And so we started publishing, and in this research has been fundamental. So we began by doing case series of things that nobody was doing before. So portal vein Doppler assessment, for example, I show you. But now we're doing prospective trials. We're doing physiologic trials. We're studying how portal vein pulsatility and renal Doppler behaves in different pathologies. For example, we're studying severe tricuspid regurgitation during the congestion. We're studying other techniques such as congestion biomarkers and its relation to venous Doppler. And this is how you become an expert in the field. People have to know your name, and they can know your name either through social interactions, but also through scientific publications. So it needs a combination of both, and this is the path that we're working. And I have to say, this is a very, I am enjoying it because we're creating knowledge as we are disseminating it.
Thank you, Eduardo. I think so. It was very beautifully said, actually. So there's one more nice comment here from Dr. Yusuf, who I know from SKMC. Thank you a lot, Doctor. I was honored to be one of your students in the Pocus course in Abu Dhabi. I am now performing venous Doppler for assessing congestion in critical care patients. I'm currently in the learning phase, so I'm using other parameters as well. But as you believe, and everyone speaks the same language, it will be much more utilized. Thank you, Eduardo, for giving us your time. And I keep telling my juniors, I was the future once, and now there's iPhone 20s available, and they need to be worried that there are people like you out there who are their competitors. And I'm hoping your talk, your work will inspire them to do more, and hopefully that way it will help our organization to achieve excellence. And I appreciate your time. I know it's very early in Mexico, and inshallah we'll be in touch. Thank you. And
thank you. Thank you, everyone, for having me here. I am very glad to have been here.
Thank you. Bye-bye.
Thank you, Zig. Bye-bye.